we need to be very intentional about how we're working together we say the term holistic and social determinant, et cetera, but I think we have to be radical in our thinking about that and willing to cross some of the boundaries between what's social over here and health over here. So
I also think I want to underscore.
Speaking radical, New York Health Act. Just wanted to throw that in there. New York Health Act. Guaranteed.
Yeah, well, community care has to be part of that. I wanted to just underscore a conversation that Susan started, which was the disparities that this pandemic highlighted. We've always known that they were there, and we've always tried to address them. But I think we see now the lesson learned is that we could no longer we can't ignore them, nor can we just take care of it. We really need to address the causals, and go deep into what needs to be, or else we're going to continuously face this pandemic in the way that we face the situations that this pandemic caused. I think Senate, I was going to say Gustavo, the senator's district is a perfect example of a district that was affected by Legionnaire's disease, affected by many other things before the pandemic. And then it was that pandemic just exacerbated all the same conditions that helped cause the devastation of Legionnaire's disease is the same conditions that helped cause the devastation that the pandemic was able to do. So I think that as a group of all of us, both state, city, and counties, really need to look at what some of those causals are and start addressing those in a very aggressive way, so that we cannot, we're not perpetuating this. This was a great opportunity. Don't let it go to waste. Learn and move forward. The way we're looking at our community care right now is basically looking at those 33 districts that we've identified in New York who have been the most effective and impacted by COVID, and making sure that our community care plan starts there, because more than likely, those are the people who would end up in a Medicaid nursing home, and we want to prevent that as much as possible.
I'm really glad you guys brought up the sort of equity question. I was looking at a New York State Health Foundation report that, found that Black and Hispanic New Yorkers were much more likely to experience depression and anxiety during the pandemic. Low-income New Yorkers as well had really, adverse mental health outcomes. You've sort of identified all of these sort of different pieces of the puzzle that sort of, perpetuate that disparity, but can you guys all identify, what are other ways that we need to be reaching people who are, being affected disproportionately during this pandemic? Are there other steps that we need to be taking?
So I'm happy to jump in and say that I think there are a couple of strategies. Some are short-term, some are more long-term. First of all, we need to ask people what they need. We don't need to make assumptions about what kind of services and supports people need, as we have historically. We need to make sure that people bring their own knowledge and experience and decision-making into the service design for the future, so that we're not trying to, as we, again, have historically, fit people into a model that doesn't fit them. And I also think that a longer-term strategy is we need to make sure that we have diversity about age, about race, about sexual orientation, about ethnic background, about socioeconomic background for all of our boards, for all of our leadership, for all of our workforce and policymakers, so that, we have the voices there that matter. And, Susan said, this has not raised these or caused these issues, but it's exacerbated them. That's true. But as Commissioner Cortez said, we have an opportunity. It's shined a light on them, and we can't put the genie back in the bottle. We need to recognize that these are needs that need to be addressed. And fortunately, we have now the whole world's attention, for better, for worse, and people cannot look away anymore. We should not look away anymore. And we need to make those train people for this workforce and for all of these roles in the future that look like the people that we're serving.
Yeah, I would just like to agree with everything that you said. I think it's so important, but I also think we need to put in place the data and the monitoring this time around to make sure we really do it. I think that we've all, I think we will get a lot of information, and we were already out there talking with communities about what we should do, et cetera. But I think we have to hold ourselves, as an agency accountable now to look and see, a year from now, 2 years from now, 3 years from now, have we accomplished what we wanted to? And we do need tremendous feedback from the communities themselves as to what would help. But then we need to look and make sure that we're really making a difference, because I think in the past, we haven't kept the momentum up. And I think this is one time when we just have to do that.
Yeah, and I want to go back to thank you for that. And Dr. Osman, thank you. That you couldn't have said it better, because if it's not reflected in boards and any of the governance structures, we're just, people are talking to themselves again, and we're really not making the structural and institutional changes that we need. But I want to go back to use New York City as a model. And one of the things that New York City has done is identify 33 districts. And now most of our programming, and Susan knows this well, a lot of our mental health program, both Susan, Dr. Bean and Susan both know this and know this well, that all of our efforts now are to make sure that there's parity in services in those areas, and in many cases priority in those areas that have been underserved, and even funding in those areas that have been underserved. So I think I agree with Dr. Sullivan in that we need to collect the data, but we also need to start doing some strong targeting. And that's one of the things that we have done in New York. And we have these 33 districts that we consider the racial inequity districts. And we are just putting all of our attention on what's the missing and what's the gap there.
So I'll use that as a segue. Thank you. That we are looking not only at the 33 communities that were hardest hit by COVID and that also reflect all of the other social determinants of health, poverty, violence, employment, et cetera. We're also looking at the federally designated mental health care shortage areas in the city. And Thrive, which is, again, all about filling gaps in care. It's not about replacing the healthcare system or being one. It's about finding ways to fill gaps in care. 70% of the services that we support are in those designated mental health care shortage areas, and that's intentional. We have lots of mobile services and services that are citywide, but when we are citing services, we're thinking about being in areas that are historically underserved and working with people who are historically underserved and not reached. The one other thing I would add to how do we know whether we can make a great leap forward here is that we just also need to grow this workforce, and we need to grow it in a diverse and culturally responsive way. But not everybody needs to be a psychiatrist or a psychologist or even a social worker, but we need more of them. And we need to find ways to make that happen. We also need to find ways to make sure that people who are not in those categories are able to provide some level of mental health support, because we turn to them for it. And that's our faith leaders, and that's our social service agencies. People, more and more people need to realize that promoting mental health is really everyone's responsibility. We all have a role in this. And to some extent, we need to grow the workforce of highly trained people who can do sophisticated work. And we need to find ways to do that and to make the workforce more diverse. We also need to make sure that many more of us, who many of us and members of the public turn to for support, are able to give support that's the most appropriate and helpful. So we need to have that level of training going on all the time.
I actually have another question I'd like to first pose to you again, Susan. So we'll get back to you with this, but obviously there's sort of the broad big picture issue of thinking about how do we deal with a post-pandemic life. Obviously, there's going to be a lot of residual trauma and stress associated with this time. Mental health needs will still, need services and everything. What are you thinking about when it comes to future care?
Susan.
Oh, Susan Herman.
The two Susans today. So let me first start by maybe helping to draw the contrast from pre-pandemic to now in terms of people's mental health. Pre-pandemic, in terms of people living in New Yorkers, we had research that told us that about 8% of adult New Yorkers experience symptoms of depression every year, and about 4% experience symptoms of generalized anxiety disorder. In May, the New York City Department of Health did a public health opinion poll, and they found in May, so right in the height of the pandemic, 44% of adult New Yorkers reported symptoms of anxiety due to COVID, and 36% reported symptoms of depression. That's a great difference in how New Yorkers are feeling. So do we need to get prepared to ramp up our services and help people more? Absolutely. And again, how do we do this? We know there are historic gaps in care that have left tens of thousands of New Yorkers without the mental health care that they need. We need to remove as many barriers as possible. The simplest answer is we just need more. We need more and more. We need a larger workforce. We need more services. We need new kinds of options. And we need to keep creating services that are flexible enough to help people stay connected to care once they are connected. So our approach has been to add mental health support to our city's shelters, our schools, our community-based organizations, our centers for older adults, and even our police precincts, so that people can get more mental health support where and when they need it. But that's also why we've trained hundreds of employers in how to create a workplace that supports mental health, why we're training faith leaders, because they're people their congregations already turn to for support and solace. And it's why we've continued to expand our mobile treatment team so that people who need help in the community can get the mental health care that they need. I think if we continue to aggressively identify particularly vulnerable groups of people and historically underserved neighborhoods and try to embed services there as much as possible, we will be able to meet this challenge. But that's what we need to continue doing. Go where the needs are greatest in the way and using methods that are most what community members want. Unmute, Susan.
I would like to add to what Susan said, because I agree with everything that she said. And I think from the healthcare delivery side and the way that a managed care company looks at it, we are wondering if there is a structure of care. I think, and you mentioned this earlier, that will make sure that seeking care, receiving, identifying that you need care, seeking care, and then having the best outcome from care is a more orderly process. And what can we do in a value-based world to see that happen? I do think we have to take the pieces that we have now and make sure that they are as available as possible, knowing that, as you said, Susan, it's not enough capacity. But we have to be sure that we are aligning ourselves as agencies, as plans, as providers to deliver that care to these communities that need it so much in an orderly fashion. There's been a lot of research around disasters and what happens after a disaster, and just very hopeful that that could be another lesson, another great best practice that comes out of this pandemic for New Yorkers, that there's sort of an orderly way that care is received and no one is sort of feeling like they can't get to what they actually need in a timely fashion.
I would just like to add something that may sound very basic, but it's essential. We need the appropriate funding and policies to support all of the ideas that we're sharing today. We've been very fortunate that the state was quick to issue waivers and loosen regulations so that we could do what we needed to do with flexibility and make a nimble switch in the type of work that we were doing. And I think that by and large, it has proven to be successful. The kind of pressure around finances and regulations really has allowed people to do the work and for people to get access as best we possibly could, I think. And I thank OMH and I thank the government for that. But I think we have to, we have to look at that over the long term, and we can't dial all of that back, because if we do, we're going to lose any of the traction that we made. So I think it's going to be so important. I know there is a great deal of funding that's going to be looked at, both federal and state and local. But just if we can keep in mind, of course, we need to have regulations, and we need to have things in place that are ensuring that there's not fraud, there's not abuse, and that outcomes are and quality is at the forefront. But I think that by and large, we've proven as organizations that we really are altruistic. We're trying to help people. We're in many cases not for profits. We're not doing this, because we're making big corporate profits. We're doing it because we care about people and we care about our communities. So those are, funding and policy, very, very basic, but very important going forward.
I just want to. I'm sorry. No, one thing, quick thing, and I'm sorry. I absolutely agree with you, and I think a big part of that is a lot of what the state is doing on parity. I think that there's been an issue for a long time about mental health services, and it's kind of built into a lot of our reimbursement systems and a lot of the way that we design care. And I think that concept that mental, mind and body have to go together, and there has to be a parity in many ways, I think is critical. So I think with everything you said, Charlotte, and I also think that work on parity, which is being done in New York and in other states, is also critical at this point. Sorry.
No, never sorry, because what you said was so important. I want to just underscore what Charlotte said. I mean, we're very fortunate that we have Thrive, and Thrive was able to fund geriatric mental health. So if we're talking about gaps, we need many more geriatric mental health programs. We have a major need and an increasing need. This population is growing. By 2040, it's going to be one in 5 or 1 in 4 throughout the state. And we don't have enough services of geriatric mental health. But then, don't get me started on the combat ageism conversation, but because that's another strong one. But, we're very, very grateful that we've been able to have 40 of them in the city of New York because of the Thrive initiative. Had that not been there, we would not have been able to create those kind of services. And that is that. And now more than ever, we realize how important they were.
And with that, I'm afraid we're all out of time for our first panel. I'm sorry we couldn't get to the Q&A for all our audience members who submitted questions, but hopefully we'll have time to address some of those and throughout the rest of the event. Appreciate you all for joining us today, all of our panelists. It was a fruitful discussion, and it was great to participate with you all.
Thank you, Jeff. I also love your 3 kings. Bye.
Thank you.
Thank you.
Bye-bye.
Thank you so much to Kay Dervishi and all of our panelists for that great discussion. You know what? I'm going to take this opportunity to once again. Oh my goodness! If I can find the document, we have a lot of sponsors. Sorry. There you go. Hey, I want to thank again Health First, Metadata, T-Mobile, Brown and Weinrub, Emblem Health, Healthcare Partners IPA, Healthix, Somos, Primary Care Development Corporation, AmitaCare, CVS Health, Hinman Straub, the New York State Conference of Blue Cross and Blue Shield Plans, and Elstroff Associates. So thank you again. And with that, I think all of our panelists for the next one are here. I want to hand it over to one of my favorite reporters, Maya Kaufman, recently joined Crain's New York, and she can handle the rest. So over to you, Maya.
Thanks so much, Jeff. So to start off our panel, I wanted to give all of our panelists about 30 seconds to introduce themselves before we go into questions. If we can go and do that now.
Everybody's being excessively polite. I'm happy to start. Karen Ignani, CEO of Emblem Health.
I'm Assemblyman Dick Gottfried. I chair the Health Committee in the New York State Assembly.
Hi, I'm Louise Cohn, CEO of the Primary Care Development Corporation, which is a community development financial institution dedicated to achieving excellence in primary care and expanding access.
And Chairman of Somos Community Care, Dr. Ramon Talach, internist. Thank you.
Hey everybody, I'm Mark Levine, City Council member from Northern Manhattan and chair of the City Council's Health Committee. Really excited to be here. Thank you so much.
All right, thank you everyone. So the title of the panel today is Making Healthcare Available and Affordable to All New Yorkers. That's going to be the underlying thread of our discussion of all of our questions. So I wanted to start by asking all of you, how has COVID transformed the healthcare system in New York? And what gaps or challenges has it exposed when it comes to access and affordability? Who wants to start?
I'll start. I don't think it has transformed the healthcare system. It might have been good if it had. It has certainly stressed it and damaged it. But all of the problems that COVID has exposed and sharpened or deepened in the healthcare system have been there for years. COVID has made them a lot more visible. Maybe that will help promote transformation in the healthcare system. I hope so.
I agree. I think that's very well stated. I think it has shined a spotlight on the disparities and inequities we knew that existed, that has exacerbated under this pandemic. And it has also really shined a spotlight on the historical underinvestment in public health over the last 30 years, decades. And I think that it points the way to where we need to think about resources, think about folks who should be first in line and communities that should be first in line. It also, I think, made it very, very clear that while folks are very appropriately celebratory about the ability to pivot and do and make access broader with digital tools, it also shines a spotlight on communities that have been underserved by Wi-Fi that's not stable, or communities and families that haven't had enough devices for children to be schooled at home, for people to be at work and engaged, and then also be on a medical appointment. So we need to do more there. And finally, I think it really shines a spotlight on the lack of investment in primary care. And we've all talked about that over decades, and the important role that primary care physicians have in keeping their communities healthy, but being the beacon for change in the delivery system.
Yeah, if I can add on to that, I mean, I think both what the Assemblyman said and what Karen said is absolutely true, that COVID didn't transform the healthcare system, but it shined a spotlight on our issues. And I think in particular, it shined an enormous spotlight on this issue of equity and health equity. And while I think our organization and everyone else on our panel has thought about equity for many, many years and tried to address it. I think that wasn't necessarily true before the pandemic, that this really opened up a much broader conversation about the issue of health equity. And I think, though, that the pandemic has had perhaps not a transformative impact, but has had a very significant impact on the primary care system. EDC just came out with a report that said that 16% of ambulatory care jobs in New York City, we've lost 16% of our ambulatory care jobs over the last year. In hospitals, we've only lost about 1.3%. So that is a huge proportion of the primary care healthcare system that may or may not ever come back. And I think the other point is that while we're all talking about disparities and health equity, we actually have to think about how we're really going to transform our healthcare system by really moving money into those communities and moving money into the parts of the healthcare system that have been under-resourced. And unless we do that, we'll just be talking about equity and talking about addressing disparities, but we actually won't be able to be doing that in a measurable way.
Well, I could mention this, Dr. Talach. Something different since on first hand has seen what happened in our community because I've been there. And not behind any desk, we were right in the spot where we see people suffer, get sequela of the disease and die. In my own flesh, my family, and people that we know with faces, not with numbers. We have seen that again and again. The loss of jobs is number one for them. The loss of food, the loss of insurance, the inequality to be able to teach their kids or go to the outside to work, to bring home food or pay the rent because the two parents have to work. Only one does that. Those people, we could keep talking, nobody cares so much because those are the kind of things that we cannot talk about it. And I want to continue talking since that we cannot talk about it, that we deposed during this pandemic. First, with about 2,000 doctors in the community, 700,000 patients and Medicaid, poor people, poor community. There's no one of us working in Park Avenue, probably where most of the people goes to see their doctors. No, we only take care of Medicaid patients in those neighborhoods. And we've seen since that it's difficult to understand. This is the way I saw this at the beginning. I saw no buildings. I saw millions of people in the fence. The only line of work for them was somebody to go and tell them what's going on. From the federal government, not only the president, but people close to the president who now is still in power, say don't use masks. We were saying we need to get the mask. It's in the air. We were talking about China sending planes or Europe sending planes, but we keep the air open and we imported the virus everywhere. And nobody cares. We can talk about that because we problem for somebody. Then during this pandemic, we were testing the first testing site. Nobody gonna go to the stock exchange. We took the chance. We need to open the stock exchange. We went to Queens. We told them, because we put telemedicine with 3 languages to be sure that people could call without insurance, without papers. You just call. We were here to serve. Millions of calls. We increased the people working there. We put the saving that we have in what they call value-based payment. That thanks to Mr. Gottfired and the people in the government and the governor create district that we had enough resources to in this pandemic confront head front. It was hard for me when that was coming. For example, I asked an insurance company, lend me your van. I want to have a place to dress my doctors while they're doing testing. And they say no, because that could be contaminated. But here you go, Mr. Gottfired. All the millions of dollars goes to them to take care of the communities. They are the one managing every single dollar. And they deny a ban for the doctors who really were in the front line. One more front line. When the vaccine came, there was not to be found that we doing the testing in the community get the vaccine first. As a matter of fact, we got like a month and a week after. They went to hospital. It's the first war that I'm seeing that the warm people happened in the hospital. One people happened in the communities where we were. We were the ones sending patients to the hospital because the one happened was the front line. We didn't get a vaccine until a month and a half. Still, we've been doing a lot of work in the center side, thank God to the governor and the mayor who understand our role in the communities, but we don't have a vaccine for our officers to give to our patients. They choose us to be the primary care. They went first to the hospital. For a month, they were storage. And then they went to urgent care centers because of lobby. And then they went to pharmacies. My God, where are the doctors in the equation? Who's doing healthcare? Who's doing prevention? Who are the champions? Who else is? Who are the people trust in the community? They choose the doctors. You choose your own one. The poor people did the same in Medicaid, but they don't have the tool. The tool we got, thank God, because we have money saved during this rip. And this is the kind of thing that sometimes is difficult for me, but yes, with the government, healthcare need to change. You need to go to a group who's always looking to money to do fee for service, to a value-based payment, where you have enough time to save money. I had, like my mother did, my father give me 20 pesos a day. She used 15, save 5. By the end of the week, when we're gonna do something or some emergency happened, there was somebody with money to save the day. It's not happening anymore. I don't think many people know what I mean balance the budget. You know, this is the kind of thing that we could not talk about, but I decided to mention in that direction. Look at it happen now, since Mr. Our member, Councilman Levine, created things about the appointment things. At the beginning of this, nobody knew how to create a website to do the testing or to get the vaccine. We did it with the same resources. Even we were abandoned with the resources to continue moving ahead in the IT world. We were saving, we did it. And we helped the city and the state to get appointments, get results, and get appointment for vaccine. Yes, healthcare has need to change, but it don't need to change at the level that people have never smelled one Medicaid patient, see one of them die, or one of your dentists, you cannot find it because it was in a truck, in the wrong truck. That's where we live. That's what we are. This is Somos.
Well, my goodness, Dr. Talaj, thank you for everything you just said and for what you and Somos have done for this city over the past 13 months. Really, the impact is beyond words. And I know we have a lot of questions to get through, so I'll try and be brief. I'll just say that I think that the last year has exposed real weakness in this city's ability to communicate to connect to physically reach, to build confidence with, and ultimately care for marginalized communities, whether it be immigrant communities, African-American communities, low-income New Yorkers, at every stage, from testing to contact tracing, now so clearly with vaccination. And we have got to address this and invest properly so that we are better prepared for the next crisis. And I will say that I'm optimistic on that front. You know, after 9/11, the city invested, the country invested in unprecedented ways in security. In some ways too much, I would argue, but that's another story. After Hurricane Sandy, we started investing much more in resiliency. Still more work to do there. And I really believe that coming out of this crisis, we are going to invest in health equity, in primary care, in better public health systems. We must. We're never going to have a better opportunity. We're never going to have a more compelling case. We're never going to have the attention of the public the way we do today. So it's urgent that work starts now. But I am optimistic that we have a once in a generation chance to fix what's broken in healthcare in New York.
Along those lines that some of you have already brought up, what has the pandemic taught us about developing solutions to these issues of access and affordability, but also, as you brought up, trust and equity?
Well, I don't know if that was for me, but I'm happy to take it, Maya. What has it taught
For all of
us?
you.
What's taught us is that one size fits all is a failure, and that we need targeted strategies for every community in this city. That that means we speak in the languages of the city, that we be located in the communities on the blocks of this city, that we have cultural competence, that and that we lift up trusted messengers in the medical profession, and that we mobilize community leaders more broadly. And we are confronting right now probably the most dire consequences of this challenge, when we're at a pivot point in vaccination in New York City, where the large number of people who are incredibly motivated to get an appointment have largely been able to do that, thanks to expanded capacity, thankfully, finally. But that still leaves more than 50% of adults without even one shot. And you've probably all seen the coverage today about the fact that appointments are going unused now at sites all over the city, or at least are moving much more slowly. We're going to have to dramatically expand our work to reach people where they are at, through pop-up sites in NYCHA community centers, through mobile sites, through the offices of primary care doctors. Thank you, Dr. Talaj. Through home-based vaccination for people who can't leave their home, and messaging that takes advantage of the assets I mentioned, by raising up trusted local leaders, by tapping the multilingual skills of the city and the cultural competence of local players. This is the moment that the stakes are highest in that work, if we are going to vaccinate everyone in the city. And you all know that we don't get beyond the pandemic unless everyone is protected.
I think one of the things that we've learned is the communities that were the hardest hit and the most disinvested and had the worst health status are the communities who got sickest and died from COVID, right? Which says to me that those are the communities that actually need more afterwards. We can't do the same that we did before, right? One of the lessons out of all of this is that those are communities that deserve much more investment. I think there's this, we talk about we've talked, I guess, for a couple of years now about, a tale of two cities, but let's actually look at some of the data. If you look at the difference between Corona and Elmhurst and Queens and Manhattan, which actually are 6 miles apart, so not very far, the case rate in Manhattan is 4 times lower. The death rate is about 6 times lower from COVID. Before COVID, there were 27 times more primary care providers on the east side of Manhattan, all going up and down. The per capita income is twice as high. And very importantly, the federal COVID relief to hospitals was almost twice as high on the east side of Manhattan as it was in Corona, Queens. And that just tells me we still have a lot of work to do to put the resources in the right places. We know that that vaccine availability has really been varied depending on who you are. And white people have had much more access to vaccine, and they're now vaccinated at almost twice the rate as at Black and Brown communities. And that's actually something that we can do something about right now. I agree with Councilmember Levine. I think it's past time to get the vaccine in the hands of primary care providers, to have vaccine in NYCHA housing, to have vaccine in all the very key places that we know people live, so that people aren't needing to travel. And I think that I could imagine a different scenario if, as Dr. Talaj had said, imagine if at the beginning of this pandemic, we had really leveraged the primary care system to do what we know it does best. It has trusted relationships with people. It works with people in their same language. It has the confidence of people. And we know that from surveys all over the country. When you ask who you have confidence in, your family doctor is really high up on the list, much more so than hospitals and the healthcare system more broadly. So if we had leveraged the primary care system much more broadly to provide care triaging for people who were sick with COVID, but perhaps just needed some counseling about whether they should go to the emergency room. That was something that we just never did. So all the emergency rooms and hospitals were oversaturated with some people who didn't necessarily need to be there, but they didn't have an alternative place to go for a variety of reasons, including the fact that many primary care providers were being affected by COVID, just like the rest of their community. And so if we if we sort of think now, well, why aren't vaccinations going through the primary care system, in addition to the large scale throughput, as I think really was needed at the very beginning of the vaccination campaign. But now we're really talking about digging deep into communities. And when you dig deep into communities, you go to their primary care providers, and they're trusted folks who have been doing vaccinations for years and have a lot of experience in working with families who might not otherwise be willing to get vaccinated. And not only do we have to help them with getting them vaccine, but we also have to provide them with the ability to have their staff on board to do outreach to their patients, to say, listen, I haven't seen you and I haven't talked to you in a couple of months. I need you to come in and let's talk about getting you vaccinated. They need people to do that outreach from their primary care practices, and then to be able to draw in those people that they have very strong relationships with and that we know are some of the people who currently aren't getting vaccinated.
I wanted to go back to what Dr. Talaj was saying and then connect it to Louise, where you just ended. As part of our organization, we have a 40 practice physician group, Advantage Care Physicians, and we work very closely also with Dr. Talaj and Somos, and it's our pleasure and honor to do that as well. And all of these practices, both Somos and Advantage Care Physicians, they didn't close during the pandemic, not a day, and remained open to serve the patients. And as we think in New York, often, in the past at least, when we've talked about health challenges, public health challenges, the discussion has frequently begun with the hospitals. And I think what the panelists are saying here is that if you want to address disparities and inequities, we have some of the best hospitals in the country, and we're so pleased to be able to have that and take advantage of that. But you really have to get back to the communities and to the physician practices that look like their communities, that serve their communities, that have the trust of their communities. That's where I think we can really move the needle. And I think in the public policy debate and discussion, it's really time to turn the dial and really focus on physician practices, to not to the exclusion of community-based organizations, which are a very important part of this, because we have to deal with social determinants of care, food, transportation, loneliness, isolation, and that's going to be a very important part of the going forward plan. But really turn the dial to start thinking about the community, the physician practices being the benchmark for how we build to address inequities and disparities.
I might add a little bit regarding that, the next step, we should look that as an example of what happened.
Yes.
Nobody knew anything about pandemic. Our scholars of the big universities in this country were all hiding under the bed. There was nobody saying what they're supposed to be saying about masks or things like that. That's bad to say. But we need to look to the future. That's what I say. You cannot talk about what measure was wrong, what measure was good, what this governor or the mayor or the president. But we need to look at the future. It's recovery. And in that recovery, we have to be clear what measures should we take. How do we pay attention? We have to be stopped that the lobbyist people who make so much money creating things are the one deciding how the things to be used. This country needs to look different. It's a way to reimagine. I'll give you some example. The family, the Gottfired is here and Mr. Levine who are in government. I'll give you one example. When I heard that how the money is distributed for the Medicaid patients, who decide how much money each patient value? And I look at it, I said, it's a corporation called 3M. I'm sorry to mention the name. Why do they do that? How do they do it? Did they put 5 different possibilities and they choose the best one who favor the rich people, the most important hospital, and then the flushing of the world, the white coat of the world get damaged, and even they want to take over them? because nobody cares, nobody pay attention to that. We have to look into every piece. And we need to come back with changes who really benefit the people who really suffer the most without leaving out. This safety net provider need to be protected. They were the one who really did their job in the right time. We need to look at the quality. The first thing that the government did was to take the quality money out. Excuse me, the quality money who might make the thing for you to change life and get better outcomes is the first thing you want to take over. Perhaps to give more money, I don't know, to transportation, retirements. I don't know. You know, we have to have something now. New York, United States is #1 place in the country, the world. We have to come back. But in order to come back being better than what we were, we have to come with really progressive changes who really are the ones that the people on the bottom want, people need, based on what we just saw that happened in our neighborhood. It cannot be cutting quality. You know, it cannot be doing things that retrospect go back because somebody in power want to decide that based on whoever surrounded them. We have to pay attention to everything. And I'm willing to work out with you, Mark, to tell you all the things that we have created and we have enhanced, working with Henry, to take a look at the thing that we have saw in our polls and how we could confront that in our point of view. Certainly, it's different point of view.
I want to move on to, while we're talking about solutions, talking about how New York is actually getting that done, and talk about the recently passed New York State budget. What are some highlights in terms of healthcare access and affordability that were passed as part of that budget, but also what was left out of it? And then going forward, what is next to build on that? So maybe Assemblyman, let's start with you.
Well, fortunately, we rejected all of the cuts to Medicaid and the healthcare system that the governor put on the table. You know, I said in the budget discussion that this is the 34th healthcare budget I've worked on as health chair, and it's the first time that I can say we didn't actually do any damage in the budget. Now, not doing damage is a pretty low threshold of success, but over the decades, to be able to say that we did no harm is really quite striking. We did a little bit of good. But what was clear is that we have not overcome the fact that for decades, New York's healthcare system has been forced to live on an austerity budget. We have had a cap on Medicaid spending that is not related to real inflation or the growth in the Medicaid population, or the fact that it is increasingly older and older and therefore needing more and more expensive, particularly long-term care. And so the Medicaid cap is effectively an annual cut in Medicaid spending. We made some enormous strides in funding for education, but really did not move forward all that much on healthcare. And until we break out of this mold, we're going to be stuck there. And part of the problem is that the government's role in healthcare is still seen as, in terms of funding, primarily serving poor people. And that's great, except in America, programs that serve poor people almost always tend to be poor programs. And that's why I think it is so important that all New Yorkers, rich and poor alike, no matter how you got here, et cetera, all be in the same program. Because when we are all in the same program, then New Yorkers with wealth and power will make sure that the program treats them and their doctors and hospitals as well as can be done, and 20 million other New Yorkers will benefit from it. In case anyone hasn't heard me talk before, I'm talking about the New York Health Act. I don't know any plan on the table that can solve the extraordinary problems we have in paying for healthcare and accessing healthcare in New York.
Well, if I say something regarding, I would say thank you to Mr. Gottfield, what, especially because it was a lot of protection. Since going for important behavioral health, it's very important because we know we have 50 times more problem with behavioral health than we had before the pandemic in our neighborhoods. And it's going to be a long way before it goes away. And you dedicate that. Telemedicine is important and you pay attention very close, but in telemedicine, we want to be sure that you be careful, that the insurance doesn't want to save a buck and then give it to a big corporation coming from outside the state to do the telemedicine to save a buck, and then the doctor gets disengaged for the care of the patients. We have to pay attention very close to how the money is being used to be sure it goes right to the place where the people live in New York, work in New York, and take care of communities, like this doctor who opened the door to take care of Medicaid patients. But certainly, a better outcome I expect. There was no more cuts. And hopefully the quality incentive was very important to continue doing the right prevention in our neighborhood is there, you know, and I really, really want to suggest to all of you that you look into this part of the quality, because I was told that because we will not have all the numbers in the regular, what they call quality measures, like colonoscopy or pap smear. Certainly nobody was on the street, and we didn't want people to go to the street. I got a story of many elderly people dying because they were getting letters from the plan to go and get those tests. Or worse than that, the over-the-counter card for the insurance. They go out to try to get $50, and since the pharmacy, they catch the viral and both die. We have to be sure that this kind of things doesn't happen again, that we're paying attention to those details. We are not just sitting on ourselves executive. In the case of me, which we're looking at detail that actually could save life, it would take measure before it happens. And nobody who's now in the front line would know that. But when I say it's the first time we see at least that the payments might be less with the pass of this budget. And we say thank you to you and to the legislation and the governor to come together and try to protect the safety net in our communities.
I completely agree with that. And I think there are two elements that I'd just like to add to the conversation that I think are particularly important. The eliminating premiums for people in the essential plan so they could actually use services and wouldn't have to worry about if they didn't have the financial resources being inhibited, number one. So, Mr. Chairman, thank you for that. And two, I think to Dr. Tolage's point about paying attention to what is happening at the bedside in the community, the initiative that was passed for postpartum women who've just had babies, who perhaps are in a situation where they're no longer eligible for Medicaid, but allowing them to continue and get the care they need. We know depression, particularly at this time when people are isolated and alone, is growing. And I think Dr. Tolage is right that the whole issue of behavioral health care has to be looked at far more broadly. And I know the legislature is focusing on that, and I think that's very important. I think we have some opportunities with training grants to our public colleges and universities to help develop the workforce that's going to be necessary for behavioral health, to deal with loneliness, isolation, depression, all of which have become very manifested in this time. And we're going to look to the future, as Dr. Tolage also said, I think is very important to think about what is the workforce that's going to be necessary? How do we support that? And how can we all work together to train, think about licensure in a broader way? So it can get people to work to the top of their licenses, give them flexibility, and really think about remaking the system so when we complete our job, inequities, disparities are not part of the story the way they have been for so long.
Yeah, I would agree. I would agree with everything that's been said. And I want to echo the thanks to the Assemblyman and to the legislature for really holding the line on a lot of things that would have been very, very damaging to community health. The 340B program is a good example where it would have yanked millions of dollars out of the safety net really for and really would have been pretty harmful to a lot of safety net providers out there who work every day on the front lines of the community. I do want to raise one other thing that hasn't yet been talked about, but I think one of the things that we learned during this pandemic is that regulatory flexibility can happen pretty quickly. It happened this time because of sort of emergency declarations, but we know that all the regulatory framework that enabled telehealth to be used widely, that changed very quickly, and I think we really appreciate that. I would say that in the future, one of the key things that we need to do is really have additional regulatory flexibility, particularly for behavioral health and primary care integration. That's something that needs to happen, and we need to really take a look and change the regulatory framework, which has been promised for a while, I think, by the administration. Really hasn't happened yet at the state level, to make sure that we can streamline very, very quickly those regulations so that we can ensure that behavioral health and primary care go hand in hand. You know, it shouldn't have to matter which door you walk in first to get services. If you are connected to a behavioral health provider, whether it's a substance use disorder clinic or whether it's a mental health provider, you ought to be able to use that door to get into primary care. And similarly, if your first door that you walk in is primary care, you ought to be able to use that door to access those key primary care services, because we know people, you know, they're a whole person. They're not a set of conditions. Then we shouldn't make them have to go all over in order to get the services that they need. We know that coordination of those services really matters. And so I think that that's something that I would hope that we've learned a little bit about regulatory flexibility, and that we could really move very quickly in this next period to just change the framework to enable primary care to be much more accessible, because and behavioral health sort of in the same place, because we know we can do that now, and it's been proven with the telehealth regulatory flexibility that has been so instrumental in this pandemic. But the next stage, and I think if anybody listened to the last panel, it was all about the behavioral health needs and the system that needs to be in place post-pandemic, during now and post-pandemic. And I think this is one of the key issues that we're going to be facing. It can't be seen as two separate systems, because people are whole people, and they have all kinds of needs, including chronic health conditions, sequelae from COVID, and behavioral health concerns that all need to be addressed.
What issues related to this topic of access, of affordability, are being overlooked right now or not getting sufficient attention? That can be on the local, the city level, the state level, or the federal level.
Here's an example today, what we have here today, that we're paying attention.
Yep.
Look at this panel. We're looking for solution. And that's New York. We're going to race from this, but we have to do it together. And we have to pay attention to each other. We live in a place that we cannot get away from. This is where we are. What we have to do is this: have this kind of forum, conversation, and come with solutions who really address issues. I remember maybe the first one saying in the press, how many people are dying in my community? I want to know. And the Black community, they say that in March. The numbers came and we saw it. Unfortunately, 12 of my doctors died. No hospital has any death. We got 12 of our guys died. And most of them pediatrician, because kids were discharged early, because not to have the parents in there. But we didn't, at that time, the people in Washington were saying it's not coming from the kids, you know. But I believe there's a great thing happening with this kind of dialogue that should open the way and clearly be sure that solutions come not because somebody had the best lobby, had the most money, it's because we have the best solution to take care of the people who really suffer the most.
Yeah, I think that's exactly right. And what worries me is in the middle of this great city, people who live in large buildings or are completely isolated. Some have been afraid to go out. Some are very depressed. Some are worried about vaccines, and we have to do more in the education and that's where I think primary care and physicians and nurses who are trusted messengers have such a role to play. But loneliness and isolation